Well, good morning. Thank you for attending this Mantle cell lymphoma session. My name is Sven de Vos. I'm from the UCLA Lymphoma program, and we have about an hour and 50 minutes to talk about this disease that you're all interested in. I understand there was a session yesterday, and how many of you have been at yesterday's session? Okay, very good. So you may get two perspectives on the same disease, and if you had any follow-up questions that didn't get answered last time, you can feel free to answer them today. So I have a set of slides. I will go through them. I encourage you to interrupt me if you want some clarification as we go along, and there's time for questions afterwards. So let's start. So as you know, mantle cell lymphoma is an uncommon lymphoma. It's just 5 to 6% of the large group of non-Hodgkin's lymphoma that we kind of follow. These is a disease that in the past had hidden amongst other subgroups, but we're now very good in identifying it early. And so as we have many lymphomas to keep apart, we in general think of the group of low-grade lymphomas and high-grade aggressive lymphomas. The aggressive lymphomas grow very fast. They're dangerous. They need to be treated right away. But many of them are curable because they grow so fast that they're sensitive to chemotherapy. The low-grade lymphomas, they slowly grow, and we often don't have to start treating them right away. We can watch and wait. And there are many, many things that we can do to push these lymphomas back. But we think of them more as of incurable. Although there are patients that we have treated, and 10 years later we still wait for the disease to come back. So there's a big spread as well. Now, mantle cell lymphoma is somewhat in between in a way that it looks, under the microscope, it looks not aggressive. It looks like a more low-grade lymphoma, but behaves like an aggressive lymphoma. And it has this incurability attached to it as well. So that's a group that was very important to identify because under the microscope, it looked like a low-grade lymphoma, and people were wondering why are these patients not doing like a follicular lymphoma patient would do. And so it's very important that we are able to identify this from the beginning and treat it differently. So how do patients present with mantle cell lymphoma? So sometimes with no symptoms at all, and it's a surprise finding. And it might be found during a screening colonoscopy or some abnormal blood tests. But patients can present with lymph node enlargements, with low blood counts if the bone marrow is involved, with what we call B symptoms. These are fevers, night sweats, or weight loss, or gastrointestinal symptoms, change of bowel habits. You don't know what's going on. It turns out to be mantle cell lymphoma because those cells like to go to the gastrointestinal tract. And so as we said, this is an uncommon lymphoma. It's a disease of more of the elderly. Median age is 68 years. You wouldn't call it old, but it's not a disease of young people in principle. And strangely enough, there's a male predominance of 3 to 4 to 1. It's more a male disease than a female disease. And staging has a different meaning in lymphoma than compared to lung cancer, breast cancer, because lymphoma has the immune system has no home, so to speak. It's everywhere. And mantle cell lymphoma is a problem of the immune system. And we often find these cells then in many places in the body, and therefore we have stage 3, 4 disease in many patients if we look thoroughly enough. And most patients will have involvement of the gastrointestinal tract, even if there's no symptoms whatsoever, but some of the cells might hide out there. So in order to make the correct diagnosis, we need a very good biopsy, ideally a whole lymph node, or at least a very good core needle biopsy. And then there are special tests that look at cyclin D1. That's the hallmark of the disease, and there are chromosomal rearrangements that lead to the cyclin D1 overexpression, and we can identify that with FISH testing. And in addition to that, we look at how fast the lymphoma is growing, the proliferation rate, the Ki67 proliferation rate. And certain gene mutations are very important that we need to know, and that is there a mutation of the TP53? Because we know that patients that do have that have a more aggressive course. So those are the things that you would like to know at the beginning at the diagnosis of mantle cell lymphoma. So cells only do what genes tell the cells to do. And one of the hallmark changes is that two genes are being put together. Then we stage. We want to know where diseases are located, and so often that includes PET-CT scans, bone marrow biopsies, colonoscopies, looking into the stomach. Even though this disease is very rare, it is very heterogeneous as well. Not everybody's mantle cell lymphoma is the same. There are mantle cell lymphomas that are very low risk, very well behaved, and you can actually watch them for a while. On the other end of the spectrum, there are very aggressive looking mantle cell lymphomas. We call them blastoid variant or pleomorphic variant, and they have a high growth rate. They have many additional genetic aberrations, and that's why they behave more aggressively. And they often have these mutations of the gene p53. So if you can identify those patients in the beginning, we think of these diseases differently and treat it more aggressively than if a patient has a low-risk disease, has no symptoms, and has a very low proliferation rate. So it's very important in the beginning to look at the risk of any newly diagnosed. Yeah, it's just not working. I'm pressing it all the time. Oops. Here it is. Okay. All right. Good. Maybe I had my finger on it. Yeah.
Do you want questions at the end?
Yeah, sure. No, ask questions.
Okay. That IGHV hypermutated, what test determines that? Whether it's
yeah. So you want to know if the cell that gave rise to the mantle cell lymphoma has in its real life seen antigen already trying to fight an infection or not. So if the heavy chain gene is mutated, that is a more educated, more stable, more grown-up immune cell, and a lymphoma that derives from that may be more benign. Whereas if you don't have that, it's a more immature cell, and it's a lab test that you send out, and pathologists will measure that, and within a few days you have that result. So we would like to predict the future, and we would like to have some factors that will tell us how a particular patient may do, and the MIPI, score predicts outcome, and so we can, with very easy factors, age, performance status, LDH, white cell count, and growth rate, we can come up with a assignment to low, intermediate, or high risk, and that kind of helps understand how patients do and help select treatments and help understand outcomes of clinical trials. Not every trial has the same composition of patients. It's important to know, what risk level patients have been enrolled in any particular trial. So that's something that we can assess also in normal patients outside of clinical trial in the clinic. So it's important to understand some of the genes that drive the disease, and one of the most important, as I pointed out, is the mutation of p53. Patients that do not have these mutations do much better. Patients that do have it, their disease seems to be very refractory to chemotherapy, and if you're just looking at outcomes based on chemotherapy alone, that is not that good, and for these patients we do need different treatments that don't care about the chemotherapy backbone that much. Yeah. So these are not common in clinical practice. The p53 mutation you may get as a standard test, but the other mutations not, and it's not completely clear yet what they mean. But p53 stands out. The Ki67 proliferation rate stands out. Those are a piece of information that you can use in standard of care clinic. So again, so we have patients that have indolent mantle cell lymphoma. They often look like CLL a little bit, but happen to have this 11-14 translocation. They have this mutated immunoglobulin heavy chain gene. They do not have the p53 mutation. And so there's a chance to observe these patients before down the line treatment may be necessary. And these are data from ASH 2 years ago from Dr. Kumar, Sloan Kettering, showing that there was no detriment in patients that could be observed and then treated later versus patients that were treated right away. You don't not lose anything if the mantle cell lymphoma is low risk. You can actually wait before initiate treatment. Now, what do we do standard of care-wise today? In patients that have no symptoms, we can observe. In the rare patient where the mantle cell lymphoma is very localized, we can think of chemotherapy and radiation therapy. That's more a rare circumstance because often we find mantle cell lymphoma to be stage 3 or 4. And then we wonder where to go from here. And patients that are fit, that are younger, biologically younger, we actually often do very aggressive treatments with an induction chemotherapy following, let's say, the Nordic regimen, which uses a stronger CHOP and RSC, and then leads to a stem cell transplant and Rituxan maintenance. And those are the upfront aggressive treatments in younger fit patients that lead to the best outcome in terms of not hearing from the lymphoma for years and years and years, as opposed to doing sequential treatments of milder treatment again and again and again, and maybe also having good long-term outcomes. But this is our preferred approach for young fit patients. And you know, the age of patients that are being transplanted has kind of moved. The oldest patient we have transplanted at UCLA, an oil transplant, 81 years of age. Of course, that is not everybody who is 81. It's somebody who maybe looks 70 but happens to be 81. I mean, it's always a very patient-specific decision whom you want to offer a transplant or not.
When you say younger and fit, like what kind of age range are we talking, quote-unquote, younger?
I mean, I would say any age up to late 70s in case this patient is fit enough to endure a stem cell transplant. That's what I mean by that. Now, there are patients where we feel a transplant is too much, and we don't necessarily want to do that. And those patients often get R-CHOP or bendamustine Rituxan CHOP. And because of some very intriguing data showing that bendamustine is really very effective in mantle cell lymphoma, that's basically the go-to regimen. And as you will see in later slides, that's a backbone where we add new agents to see if we can get beyond a chemotherapy-only approach for patients with mantle cell lymphoma. So that's the current status of standard of care treatment in mantle cell. Although one has to say, ideally, patients should participate in clinical trials in order to kind of move the treatment along and get to better tolerated, more effective treatments. So what was very encouraging to see that in these patients that do undergo chemotherapy and have a stem cell transplant, receiving then maintenance Rituxan versus not getting maintenance Rituxan, there was a dramatic improvement in outcome. And not only in the risk of the disease coming back being much less when patient had Rituxan versus observation, also the overall survival was better. That's a dramatic finding, because often we find that regimens improve the time to progression but have no impact on the overall survival. Here is something that is a rather mild treatment, but it did have a significant impact in improving survival. So that is why we like to do in younger fit patients autotransplant followed by Rituxan maintenance. So bendamustine in combination with Rituxan versus R-CHOP in mantle cell lymphoma patients looks not worse. It looks actually better than R-CHOP, and has less side effects. You don't have hair loss. You don't have the cardiotoxicity. You don't have neurotoxicity. So that's why that is our preferred go-to regimen in patients that are not eligible for, let's say, very aggressive treatments followed by transplant. Although you will see people are now studying also this as an induction regimen leading to a transplant. So lenalidomide plus Rituxan is also a very interesting regimen. Lenalidomide is approved in relapsed patients with mantle cell lymphoma, and here it was tested in combination with Rituxan as an initial treatment for patients that were felt not to be good candidates for aggressive chemotherapy. And here you see that this chemo-free regimen led to an overall response rate of 84%. Almost 60% of patients had a complete remission. 2-year overall survival was 92%. So that was actually very, very encouraging. And when you look at the risk score with MIPI that was based on the experiences with chemotherapy, this chemo-free regimen did really well also in patients with high-risk prognosis, the high-risk disease according to the old, let's say, scoring system. However, it also comes with toxicities. There were patients that had febrile neutropenias, there were infections, and there was also concern about secondary malignancies that can be observed in patients that receive Revlimid.
What do you mean by no correlation with Ki-67 score? So in other words, it didn't matter which cohort that was still...
It worked in low risk, intermediate risk, and high risk patients. So a risk score it tells you something about the makeup of the disease and the treatment that was tested. So if you have a risk score that tells you this is high risk, patient didn't do so well, but you change the treatment, everything may change. What was high risk may not look that high risk anymore with a better treatment. That's what that means.
I have a question. Have you heard about spontaneous remission, permanent remission of MCL?
Well, so we see that in follicular lymphoma. In mantle cell lymphoma, that would be distinctly unusual. I would not say that that's impossible. There are patients that have this low-risk mantle cell lymphoma that have been observed for a long time. So I wouldn't exclude that, but I would say this is a distinctly unusual, although, of course, very, very happy circumstance, but it's something that I would say would be very rare. So here's the follow-up data of lenalidomide plus rituximab for initial treatment of mantle cell lymphoma that was just published. And you can see that the overall survival in this group, and here we're looking at almost 6-7 years out, is excellent with this regimen. And here you see, you just asked the MIPI score, low risk, high risk, didn't make any difference in this chemotherapy-free regimen. So you change the regimen, your risk assessment may change as well because you have a whole new basis to assess it. And so durable responses were seen and the safety was manageable. So that's an interesting regimen for patients that are not felt to be chemotherapy candidates. And because there are different philosophies out there looking at mantle cell lymphoma from an aggressive treatment side of things or from a low-grade lymphoma treatment side of things. And at Cornell, for example, the aim is maybe not necessarily do auto transplants, but maybe treat more sequentially with novel agents and less aggressive regimens. And Dr. Martin had published the experience of Cornell and showed that half of the patients were alive 7 years later without relying on stem cell transplants. But you have to kind of weigh these options when you kind of decide how to want to be treated in the beginning. Do you want to have a very aggressive treatment up front, but then you're basically done, you can reset and let the immune system recover? Or do you prefer to go through less aggressive treatments, but you have to do that more often down the road and be more often in the office and receive treatment? But there are these two philosophies of how to go after mantle cell lymphoma. You can see that with less aggressive regimens, one can be successful too.
Once you do a transplant,
Thank you.
are these treatments still available to you? Allogeneic, right?
I'll get to that, yeah.
Okay,
Yes.
Sorry.
It's the one, an allotransplant is a way to cure mantle cell lymphoma, but it comes at its risk, and we're going to get to that in a second. So here, there are many different frontline regimens that have been tested. The one that we often like to do is the Nordic regimen. It's a stronger CHOP regimen followed and alternating with high-dose RSC. The outcome data are excellent, and the long-term data available because this has been done for quite some years. And it has now been looked into also to use bendamustine rituximab instead and alternate that with RSC because we know that high-dose RSC, if you want to treat mantle cell lymphoma aggressively, is an important drug. And so here there are studies ongoing that look at bendamustine plus high-dose RSC. The data look very good, but they're very young, so we don't have 5-6 year outcome data to say, are the high complete remission rates in the beginning, are they good enough? Are they holding up over time? So we don't know that yet. But it's something to look out for. And so patients that are not felt to be transplant candidates have been treated with either R-CHOP or bendamustine, and the bendamustine data look better than the R-CHOP data. Also, when you look at R-CHOP and incorporate bortezomib, which is a proteasome inhibitor approved for mantle cell lymphoma, those data look better as well. But I would think that right now in the current environment, we often go to bendamustine as a standard of care regimen, and in clinical trials, we like to add on novel agents. I'm going to show you how that looks like in a second in order to improve outcome data. So I'm coughing a lot because I got over something. You don't have to worry about getting infected because I'm sure I'm not anymore.
Thank you for that reassurance.
Yes, I believe it myself. So, okay. So, if you look at what are interesting novel ways how to treat newly diagnosed mantle cell lymphoma patients, usually in context of clinical trials, these are 3 of those that one can consider. This is taking R-CHOP as a standard of care regimen, but adding lenalidomide to it, a drug that's approved in relapse setting, followed by high-dose RSC, and then rituximab lenalidomide maintenance. So it's a frontline regimen without a stem cell transplant. Here, this is a trial of bendamustine rituximab plus minus a pill, and half the patient will have the BTK inhibitor ibrutinib, which is approved for mantle cell lymphoma, and then patients have maintenance of ibrutinib or placebo. Similar trial is out there for the other drug, the other BTK inhibitor, acalabrutinib, that is ongoing as well. And a very interesting combination is actually, and I'll show you data in a second, ibrutinib and venetoclax. That's a very interesting, novel chemo-free combination in combination with bendamustine rituximab. So those are examples of very exciting new lines of treatment for patients with mantle cell lymphoma.
All given at once, or you get a dose of BR and then a dose of the
They're being given together, but not constantly. I mean, that's. And so here are, and I'm just showing this to you. We're not going to go through this in detail because you have to find out if you need a trial, what is available to you in your neighborhood, so to speak. But there are a lot of trials going on for older patients with mantle cell lymphoma, new lines of treatment. There are a lot of trials going on for patients that are younger. So these are usually the trials that lead to, they're more aggressive, and they may or may not include a stem cell transplant. And then there are trials that are age agnostic. They basically allow everybody who may qualify for the trial to enroll. So there's no shortage of novel approaches, and they usually use a chemo backbone and add a new drug to it. And we have so many new drugs there that you can envision there's an enormous amount of possible iterations of what you can study.
If you decide to partake in a clinical trial, do you have to be at that particular site that's doing it, or can your local oncologist administer the?
Yeah. So you can only be treated in an office that is part of the clinical trial. That's basically part of the training and part of the whole arrangement of the trial. The trial is not a suggestion that anybody else can kind of follow. It's a very regulated, tight oversight by the FDA. So it's only people that are licensed to do that trial can do that trial. Yes. Yeah. But you'll be surprised. There's a lot of trials going on in the community as well. So at UCLA, we have community trial networks, and so we have trials at UCLA, but we can kind of spread them through the community, and it's possible to give it closer to home. But you have to kind of look into that. Or you can call a big center and inquire, and we can tell you. So, does it matter how well we diminish the tumor burden of mantle cell lymphoma? And it sure does. So, when we treat any lymphoma, we're doing a PET-CT scan. A PET-CT scan is negative. That's an exciting piece of information. But it doesn't mean necessarily that all disease is gone for good. It only means at the level that a PET-CT scan can tell us something, we don't see anything anymore. But below that, there might be cells surviving in different parts of the body, and hiding in the bone marrow, hiding in the GI tract, and you don't notice. So with more meticulous, what we call minimal residual disease testing, we can do testing, and that's often in mantle cell lymphoma in the context of clinical trials, to say, well, we don't see disease to the level of what a PET-CT scan can tell us. If we now apply very finicky molecular techniques, what about getting to a level where we don't see anything with our molecular tests? Which doesn't mean that it couldn't be something going on below the level of what that test can tell you, but it's a different level of scrutiny to push the disease down. And so if you get to a level where you say, I cannot find any lymphoma cells in the blood or the bone marrow with these very meticulous molecular tests, that is beneficial. And you see that with more aggressive regimen, you achieve that better than if you just give R-CHOP alone. And that translates into better survival data and outcome data. So here you see that if the bone marrow is negative, then the remissions last much longer than if you can demonstrate the presence of lymphoma cells in the bone marrow with these tests, even if your scans looked all good.
Can you comment on the availability of MRD tests in the trial? Like, how would we go about getting?
Yeah. So what you can do, and you can do that in the standard of care setting, is to do flow cytometry on a bone marrow biopsy, flow cytometry on the peripheral blood. That's a way of looking at minimal residual disease. If you want to look at it genetically and to see if any genetic signature fingerprint is still floating around in the bloodstream or is present in the bone marrow, that would be more a research question. That's not available yet for clinical practice. So, mantle cell lymphoma, despite, let's say, achieving a remission and having long-term disease-free survivals and the disease not coming back, is a disease that likes to relapse. And so that's a challenge. And what do we mean? And how does it look like when mantle cell lymphoma relapses? So one way to think about it is that there are cells that are very close and look very similar to your normal bone marrow stem cells. And as you give chemotherapy, you may cure an aggressive lymphoma. You don't wipe out your normal bone marrow because your bone marrow stem cells, they withstand that kind of treatment. And I'm not saying that there's a lymphoma stem cell per se, but a cell that has these qualities that can survive this treatment could then give rise to the disease coming back, even if everything that's in yellow has been eradicated by your treatment and your scan says you're fine. Or there is one cell in the background that survives all the treatment, whereas 99.999% of the cells go away. And then over time, that cell can grow back and gives rise to a relapse, and all these cells now are resistant to the treatment that was given before and pose a bigger challenge. So those are the two types of relapses we kind of face. And so in order to get to these cells that just don't bother about the treatment, we have to understand their molecular differences between normal and lymphoma cells better, to kind of exploit the differences and go after those cells. And in the majority of cases where we have just resistant cells that are outgrowing the treatment that was given, we think that we have to combine novel agents. We have to come from different angles at the same time. We have to do something that kind of worked in HIV. HIV virus could outsmart any single treatment almost immediately. But if you come from 3-4 different angles, you kind of put too much pressure on the disease to outrun that. And I think something like that is what we have to do in lymphoma, particularly mantle cell lymphoma as well. The challenge there is, of course, to do that safely. Right? So cells do what they're being told by signals and by genes. And so here's the cell surface. There are receptors on the surface that receive information, and then they relay that information through signaling cascades to the nucleus, the headquarters, where the cell decides if it should grow or not. And so many lymphomas, as the mantle cell lymphomas, rely on these pathways that they have turned on and made them be good lymphoma cells, so to speak. And so a lot of the novel agents that we're testing that have been FDA approved are interfering with these lifelines, so to speak, of lymphoma cells. And so fostamatinib was one very early one that targeted SIG. Ibrutinib is approved for targeting the BTK inhibitors. There's no acalabrutinib approved as well. There are downstream agents, idalism, IPI-145, or PI3 kinase inhibitors. They're not approved for mantle cell lymphoma. They're active, but their responses are often not that durable, but they could be part of combination trials. And temozolomide, mTOR inhibitors, and AKT pathway inhibitors, they're very active. And in fact, temozolomide is approved in Europe, and everolimus would be available as an off-label use if need be here in the United States. And bortezomib, of course, is approved. Carfilzomib is a drug active in myeloma, but also in mantle cell lymphoma. And a very important drug class is BCL2 inhibitors. They're very different from any of these drugs here above. They basically take away a break, a defense that the cell has to not undergo cell death. So you can take a break away so the cell can then move on to cell death. And combining a drug like this, which is very different than any of these pathway inhibitors here, makes a lot of logical sense. I'm going to show you some data in a second. So we have those agents approved as single agents: bortezomib, temozolomide in Europe, lenalidomide. I'm going to show you data in a second, ibrutinib and acalabrutinib for relapsed mantle cell lymphoma. They all have activity. They're very promising. They last for a while, but the duration of these responses are kind of less than what we want them to be, which is why we have to think of combining these drugs with each other or with other regimens in order to come up with better, longer-acting, successful regimens. So those were the data of bortezomib, single agent, proteasome inhibitors approved for mantle cell lymphoma for quite a while now, but you see that here the single agent was much better than the control arm. And here the durations, medium time to progression was in all patients 6.7 months, but in patients that had a partial remission, 9.1 months. And it was rather doable in patients that had a complete remission. Not everybody did achieve that, but if you had a great response to it, it was doable. The drug that was approved in Europe, temozolomide, here was compared to standard of care chemotherapy regimens, and it was better than chemotherapy was approved there for that reason. And ibrutinib, I think, is the one drug that got a lot of excitement in mantle cell lymphoma because it is very well tolerated. And here you have an overall response rate of almost a little bit more than 2/3 of patients, 21% CR rates, and the median duration of the response is over a year, 17.5 months. So that was very exciting. And Acalabrutinib is another BTK inhibitor that was just approved. It has a different, somewhat better side effect profile than ibrutinib is now available as an option, as well as being tested like ibrutinib in combinations now with other agents trying to get to better, more effective regimens. Now, because ibrutinib was there first, the question was why are a third of patients from the get-go not responding to a drug? We don't know why that is. Why is the complete remission rate so low? It's just 21%. And what is the mechanism of escape? How do patients relapse after they initially responded? And if you combine this drug with something else coming from two angles at the same time, can you improve those? Can you improve the response rates, the CR rates, the duration of the response? And so if you think about that, you don't have to go that far. You go to the London tube system, and you can imagine that if you shut down the red line, that you kind of slow down the traffic. But before you know it, the system will respond to what you did, and new trains will open in the other lines, and you're back to square one. So you have to really strategically hit nodal points like this one, for example, and that one together in order to have a major impact. And so this is what we have to understand in patients' lymphomas. And it makes it a little bit more difficult that each patient's lymphoma is different than others' patients. You don't have this one-size-fits-all kind of disease approach here. But so general big themes have emerged, I think, that are very encouraging. And so when we do that, when we hit the lymphoma really hard from all angles, we have to keep in mind also hitting the immune system from several angles at the same time. So you can have regimens that look very active on paper, and they look very toxic. They may be very active in real life, but may also be very toxic. So these combination trials have to be done very carefully at good institutions and carefully executed clinical trials. And that's a challenge that we're all aware of. So no stone is left unturned, and here you just get a selection of, this is just ibrutinib trials with anything you can imagine in combination. So this is all being tested right now in ongoing clinical trials. And the one that I would keep an eye on would be this one, ibrutinib plus venetoclax, is a very interesting combination, and here with a novel antibody. Those first two, I think, are the ones that would be my personal favorites, but we will see what works and what doesn't work. But there is a lot of promising, exciting activity going on in these novel doublets or triplets for Mantle cell lymphoma.
When did that one start?
That's ongoing already at different institutions. I can't tell you for each and every study, but some of these.
The one that you thought was your favorite.
That one is that may be going on for less than a year, but it's up and rolling. It's ongoing. So lenalidomide is approved.
What stage of the trial procedures is it in? Phase 1, 2, 3?
So these are, you see, this one is a phase 2 trial, and there was a phase 1 trial done before, and then led to the phase 2. This one is a novel combination. Almost always start as a phase 1 to make sure that it's safe, and then you establish the right dose, and then you do a phase 2 to expand on the findings of phase 1. So lenalidomide is a drug that has many activities. It can directly lead to cell death. It can activate the immune system trying to fight the lymphoma better, and it often makes any antibody we give work better. So it's a very potent and good combination agent, particularly for antibodies. And it was approved, as we pointed out, for Mantle cell lymphoma. Venetoclax is the drug I talked about that is very different than the pathway inhibitors. If the immune system tells the cell, or if you give a treatment that tells the cell to die, the cell has this shield that can put up BCL2 that stops the cell death process. And some lymphomas and Mantle cell lymphomas, some of them have a lot of this BCL2 in them, and they use that as their defense. So you can give this drug venetoclax that kind of blocks that, block away, and basically lets a cell death proceed if there is a push towards cell death. And if you look at the outcome data here, mantle cell lymphoma was actually very responsive. The overall response rate was 75%, single agent chemotherapy refractory disease. CR rate was 21%. If you look at here, these are the mantle cell lymphoma patients. If a lymph node, if a patient's disease burden went all the way down to 0, it would go down here. Most patients in this trial had significant reductions of their tumor burden just with this pill alone. So this is a very good combination partner for other agents to come from different angles. So it's a very good one angle to kind of select for your regimens. If you look at what all these different novel agents do in comparison, you always have to be careful doing that because these are not fair comparisons, it's not a fair race. We just look at published data of different trials, and one has to always take this with a sort of with caution. But here you see that ibrutinib has a very high overall response rate and a significant rate of CRs, 23 out of 111, and venetoclax. So if you would be a betting person, you would like to take two of the most active drugs and combine them. Idelalisib may have not been picked here because in the single-agent trial, while it's active as a single agent, the responses were not that durable. So it was not kind of the go-to drug. So the ibrutinib-venetoclax combination makes a lot of sense. That trial is ongoing. Dr. Tam reported on those last year on the very early data. And you see here all of a sudden CR rates of 63%, which is really high. So that is very interesting new data. And these trials are ongoing as we speak. And I just give you, this is not something for you to kind of read through, but I want to point out that as we give single agents, and you see with these novel agents interesting response rates, including complete response rates and durations that might be in the half a year, 8 months, or 1 year range. If you combine these drugs, the response rates increase, the complete response rates increase, and the duration of the responses increase. So this is basically the paradigm of what we have to do to push the field along. Besides these novel agents, we have also antibody drug conjugates, we have CAR T cells, we have checkpoint inhibitors, and I want to make a few points about some regimens that approaches we haven't talked about yet. And you brought this up earlier, allotransplant. And allotransplant is a way to cure a disease that we think of as incurable. And there are plenty of data indicating that that is possible. The only problem there is, that an allotransplant is a toxic endeavor, and there is a risk of dying of complications of the transplant when other regimens would have avoided that and kept patients in remission. But for younger patients that are eligible for allotransplant, that have gone through many of the usual treatment algorithms as well, allotransplant is available, and we do that. But it's not our first go-to regimen. Now, here comes along CAR T cells. And so if you think of allotransplant in a second, what do we do with an allotransplant? We bring in a new immune system that is supposed to recognize the lymphoma cells and fight it. At the risk of this immune system to fight the rest of the body as well. We call that graft-versus-host disease. So in an ideal setting, we really would like to have an immune system that really focuses on where it needs to focus on, which is the lymphoma cells, and leave the rest of the body immunologically alone. And so that's a bit what CAR T cells actually try to accomplish. It is trying to help patients with their own immune system to fight the disease. And that approach is approved for ALL, it's approved for diffuse large B-cell lymphoma by 2 companies. A third is kind of waiting and is being tested right now in mantle cell lymphoma as well. And so what is it? There will be a session after this, and it will be in great detail, but I wanted to just tell you what this is about and what it entails for mantle cell lymphoma. So here you have a T cell, and here you have a mantle cell lymphoma cell. Almost all mantle cell lymphomas have CD19 on their surface. And T cells recognize infectious agents, they fight them, and here we try to redirect a T cell not to fight the flu or the cold, but to fight what you want it to go after by giving genetic information into these cells so that they have new detection units on their surface and recognize CD19. So, and I'll show you this in a second how that looks like, but these new detection units on the surface of the patient's own T cells will now recognize the CD19 on tumor cells and fight them. The cell thinks it fights the flu, but it really fights lymphoma. And how is that being accomplished? So one would select out of the bloodstream some T cells. Then these T cells get re-engineered in the lab. Genetic information gets inserted into the cell. And this genetic information basically is the recipe to build a new detection unit on the surface of the cell. So this is the chimeric antigen receptor, the CAR. So now you not have one, you have many, many, many on the surface, as you can see here. And those modified cells, living cells, patient's own cells, are then being given back to the patient, where they then go through the body, they find their target, they get excited, they grow, they multiply into the millions, and fight lymphoma in the body when, in fact, the immune system thinks it fights the flu. And patients actually get sick. They get sick with side effects that look like a really, really bad flu that occurred. Yes, so these modified T cells are being infused back into the body, and then they, when they find their target, it's like pushing a growth button. They will divide, they grow, they multiply into the millions. With identical copies of themselves. So that's correct. So there are 3 CAR T-cell products out there that we follow, particularly 2 of them. These are data for large lymphomas, but for instruction purpose, I put them up here. Axi-cel is approved. Tisagen lacluzole, you have to practice saying this, is approved, and Lysocell is in the process of being evaluated by the FDA. These 3 different CAR T-cells out there, CAR T-cell constructs, are different. They all bind to the same target, but they activate the T cells in different ways. The Axi-cel does it very quickly. The other 2 do it slower. That comes, it looks like it appears with lesser side effects. And the big question is, does the efficacy of these 3 products, as they are different, is it the same? Are there groups of CAR T cells that are efficacious but less toxic, or does with more toxicity also come more efficacy? So this is something that we will see as these trials mature and people get more experience doing this in the standard of care setting, as 2 of these are already FDA approved. But it's very exciting. What is exciting in aggressive lymphomas is that if you look at 3 months out and 6 months out, that there are 33, 32, 54, 52 ongoing complete remissions, which is rather striking. We're looking at large lymphoma patients that were not really responding to chemotherapy anymore. So this approach is being tested in mantle cell lymphoma as we speak. And that is very, very exciting. Now, it does come with toxicity, because when these cells divide and grow and fight lymphoma, they produce a lot of factors. We call it cytokines, and there's cytokine release syndrome that leads to fevers, low blood pressure. Some patients may have to go to the ICU to get the blood pressure supported, and you support patients through that. We do have antibodies that we can give to kind of mitigate that, and these are things that come and go. In really almost everybody these side effects come and go. The ones that we really have to follow are the neurological side effects, because this cytokine storm breaks down the otherwise well-established barrier between the blood and the brain. And so patients can have significant neurological side effects that can be from small neurological deficits to almost comatose or seizures or stroke-like appearances that, interestingly again, in 99.9% of patients come and go. But it's at times distressing for particular family members to observe that at the bedside as a patient goes through that. But those are side effects that come and go, and then you have efficacy. And interestingly, the rule of thumb is that the more you have an expansion of CAR T cells, the more active they are, the more side effects you get, but also the more efficacy you gain. And so the goal in CAR T cell treatment is really trying to maneuver this to get the best efficacy with the least toxicity possible. There's a lot of room for us to kind of improve where we are today. But this is a very exciting approach, and there are many ways how one can interfere with that. So you could potentially have the CAR T cells as they're engineered already to have new detection units on their surface. You can have these CAR T cells produce other factors that may mitigate some of the side effects at the same time. So those are research questions that are being followed and pursued right now, and it's a very active, exciting field. Because ultimately, if you look at an allotransplant, we want a new immune system to fight lymphoma, but we have the risk of this immune system going astray and fighting the rest of the body, sometimes with deadly consequences. And here with CAR T cells, we have the opportunity to have an engineered immune system, patient's own, to really be focused on the disease itself and trying to mitigate any systemic side effects. Certainly, we don't have any graft versus host effects like in patients with CAR T cells, which is why if one thinks about an allotransplant in mantle cell lymphoma, I think one should look at the options of CAR T cells before going the allotransplant route. It's something to kind of think and discuss at least. And so this is just a summary slide. We don't have to go through that. The main take-home message is, however, that in any aspect where we actually treat patients, we would prefer if patients would consider participation in clinical trials. That is not because we like to do clinical trials and like to increase enrollment. It is sometimes clinical trials are the best options for patients, and you need to know all your options and discuss them in detail that are on the table and then make a decision. Because some of the trials are a combination of very well-known active agents, and it's just the best way to move forward. So you need to know that before you just say yes to a treatment that's being prescribed to you. So we have increased molecular and pathologic insights in mantle cell lymphoma. We're trying to do risk-adapted therapy. We don't treat everybody the same. There are now very promising maintenance therapies. You have seen the data of Rituxan after stem cell transplant leading to improved survival. There are a numerous amount of novel agents and combinations. In fact, if you do the mathematics, for generations you can test all the combinations possible. So, but we think that the best ones will kind of be figured out rather quickly. You have seen how many trials are going on right now. I think the big themes that work will emerge. We're trying to rely less on dose-intensive regimens, that is, including stem cell transplant. For example, in the aggressive lymphoma field, we now have trials. We randomize CAR T cells versus an autotransplant. And maybe something like this may come to mantle cell lymphoma as well if the data that are being acquired right now on the ongoing clinical trials look very promising. We have a lot of non-chemotherapy-based regimens, including targeted therapeutics. That is particularly interesting in a disease where we have trouble curing it with chemotherapy. That's the way to go. And what will be very active field moving forward is looking at minimal residual disease. Let's say you have achieved a minimal residual disease negative state? Is there a way where you can stop treatment and follow with these molecular tests and think of restarting treatment if in the background the minimal residual disease activity comes up again? So can we then intervene early on and treat at that point before the disease breaks out full and makes patients sick? So in order to accomplish all of that and move the field forward, what we all want to do, we have to really rely on clinical trials. So we really encourage everybody to at least think about the options that are available to you to make the best possible treatment decision. Sometimes the best possible treatment decision may be standard of care, but more often than not, it's a clinical trial. These are the trials we have available at UCLA. CAR T-cell trials we listed in kind of orange. We have trials for mantle cell lymphoma that are specific for mantle cell lymphoma, but we also have trials that have many histologies included, so there are many options that we can offer patients with mantle cell lymphoma, frontline or relapsed. These are my colleagues of the lymphoma program at UCLA. And with that, I stop and thank you for your attention and ask you for questions.